Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, AskMed's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined by my co-host, Josh Davis.
I'm Josh Davis. I'm an infectious diseases physician based in Newcastle in New South Wales, Australia. And before we get into the podcast, I'm going to take a leaf out of the book of another podcast, which is called The Rest is History. And they usually start their podcast with a quote, an historical quote. Here it is. About 1.5 years ago, a few cases of human glanders infection were discovered in Rangoon, and the opportunity was taken for a much-needed effort to lessen the incidence of this disease among the Gari ponies of the town. It was owing to our interest in this question of the occurrence of glanders in man that our eyes were opened to the fact that there was an infective disease somewhat resembling but easily distinguishable from glanders prevalent among the ill-nourished, neglected wastrels of the town. At the post-mortem examination, the principal lesion discovered was a peculiar cheesy consolidation of the lungs, and upon examining smears from the diseased patches, a large number of non-gram standing bacilli of the size and shape of B. mallei, apparently unaccompanied by other microorganisms, were found to be present.
So, that was from the original description of the disease now known as Melioidosis by Captain Whitmore and Assistant Surgeon Krishna Swami, published in the Indian Medical Gazette in 1912. We're thrilled to have with us two world-renowned experts on this disease, Dr. Ella Meumann and Professor Bart Currie. They've recently published a concise clinical review that you can find at our website at CMI Communications Journal. Ella Meumann is an infectious diseases physician and medical microbiologist at Royal Darwin Hospital. She's also a researcher at Menzies School of Health Research and Charles Darwin University in Australia. She has authored several articles on melioidosis that really go from bench to bedside, from host pathogen interactions, molecular diagnostics, epidemiology, to clinical management.
Hi. Thanks for having me on the show.
And Professor Bart Currie is also an infectious diseases physician at Royal Darwin Hospital. He leads the Tropical and Emerging Infectious Diseases team in the Global and Tropical Health Division at Menzies. Bart began the Darwin prospective melioidosis study when he first moved to Darwin back in 1989. And I need to add that Bart is one of the go-to people in the world about melioidosis, so we're really lucky to have him on here. And from a personal note, Bart's been a mentor to me for many years, so it's great to do a podcast together.
Thanks, Josh, and hi, everyone. And thanks, Angela, for having me as well.
Okay, so we start these episodes with a get-to-know-you icebreaker kind of question for our guests and also our hosts. And today I'm going to ask, what is your favourite ID-themed novel or movie? Now, people who've listened before know that Angela and I have named one, but if we can, we're going to name another one today. So my second one briefly is a book called Blindness by José Saramago, who's a Portuguese writer who won the Nobel Prize for Literature, actually. And the book Blindness is about an epidemic, an infectious epidemic of blindness that spreads through a town and all the societal breakdown that happens afterwards. And it's very allegorical and beautifully written. Angela, how about you?
My choice is not as ID themed. I always struggle with this. The one I could come up with today was very ID adjacent. Again, it's not even a novel, it's a nonfiction book. I would say it's almost required reading if you do medicine or medical research. The book by Rebecca Skloot about Henrietta Lacks, who was the woman whose cells are used like crazy today. These were cells from her cervical cancer, and she was a patient at Johns Hopkins. I think it was in the 1940s that she was diagnosed and gave her samples in a clinical setting, and it was a very different time. Her doctor saved her cells. The author, who's a journalist, takes you through what happened with these cells and what happened to the patient and her family even today. It brings up a lot of issues, social issues, socioeconomic issues that we all need to be thinking about. So why is it even remotely related to ID? Because cervical cancer, HPV. That's my connection.
Everything's related to ID, right? In one way or another.
Exactly. So that's mine. Ella, You're up.
One of the books I've really enjoyed in the last few years is Derek Jarman's diaries, published under the title Modern Nature. He was an artist and gay rights activist living in the UK in the late 1980s who was diagnosed with HIV. And it's beautifully written and I would say equal parts joyful and heartbreaking. And to me, just provided such insight into a time and community that I haven't experienced myself. So I really love that book.
And Bart, how about you?
So this is in no way an original thought from me, but what I thought I'd bring to your attention is a book written in 1913 by Sir Arthur Conan Doyle, which is called The Adventure of the Dying Detective. And the interesting thing is, many of you will be aware that Arthur Conan Doyle was actually a doctor, and he graduated from the Edinburgh University Medical School in 1881. And he's published a number of books. Of his books had medical themes. In relation to the Adventure of the Dying Detective, it was 1913. Remember, it was 1 year after Whitmore published his paper in the Indian Medical Gazette. And it was about the Coolie disease from Sumatra. And this disease that he invented, he called Tapanuli fever. Tapanuli is actually a real place in Indonesia. And there was an outbreak amongst plantation workers in Sumatra, short incubation period, high fatality rate, organism easily cultured on gelatine, and it was bloodborne transmission by needle stick, fever, sweating, anorexia, fatigue, dyspnea, cough, delirium. In fact, we could finish the podcast on that probably. Where Sherlock Holmes comes into it is that the bad guy who was a microbiologist, who was a murderer and amateur microbiologist, Culverton Smith, he sent Sherlock Holmes a gelatine-laced booby trap gift from Sumatra to try and kill him, and in that was contained this organism, and there was a hidden spring-loaded needle in an ivory box. So the interesting thing is, my long-term colleague and friend, Professor David Dance from the UK, who has studied the life of Whitmore, he and a colleague from the Netherlands, Jelmer Savalkiol, published a fantastic summary of Whitmore in the Emerging Infectious Diseases in April this year. And David has been in touch with Whitmore's family and tried to find out whether Whitmore personally met Conan Doyle or whether potentially they were sharing at a medical meeting, but he was not able to find that direct link. So it is thought that potentially he may well have been reading the Indian Medical Gazette and then made this fantastic story. And that's been a number of medical colleagues over the years talked about this. That's not original from me.
It's interesting all the same, though.
So now to this tropical or no longer so tropical disease, Melioidosis. Bart, Josh read us a quote from the original description of the disease. So can you tell us a little bit more about its history?
Whitmore and Krishnaswamy described it first in 1912, and they are from cases that they did the autopsies on in 1911 in the Indian Medical Gazette. The next year, there was a laboratory outbreak in animals in Malaysia, and then in 1921, it was called melioidosis, which means glanders-like disease, which is a derivation, I'm told, from the Greek. Here in Australia, even though we have a large number of cases in the north and a high incidence rate, it was not until 1949 that we recognised it was present in this country, and that was an outbreak in sheep in North Queensland. And in Thailand, where they have by far the most number of cases, and possibly more than all the rest of the world put together, the first case described from a Thai patient wasn't until 1955, and which is interesting considering that it was originally described way back in 1912. And then in 2004, the genome of B. pseudomallei was published. The interesting thing about that was that glanders, which is Burkholderia mallei, which has been known since antiquity as a disease of horses, which can infect humans as well, is actually a clonal derivative of B. pseudomallei with gene loss resulting in adaptation to an obligate mammalian existence. So in other words, B. pseudomallei antecedes B. mallei, which somewhere in South Asia probably evolved to be an obligate pathogen of horses in particular, and no longer motile. So B. mallei is much more recent than B.
So should B. mallei really be called B. pseudomallei?
Of course, Josh. And then in 2023 was the fascinating story in the US, which we'll come to later.
So over to you, Ella. Can you tell us a bit about the bacterium itself, like what it looked like, what are its virulence factors, and what habitats is it found in?
Burkholderia pseudomallei, it's an environmental bacterium found in soil and surface water in tropical and subtropical regions globally. And during the rainy season it comes to the surface where it proliferates. It's during those wetter periods of time that most melioidosis cases occur. From a microbiological perspective, it's a motile gram-negative bacillus with bipolar staining, so it has a safety pin appearance on gram stain typically. It's oxidase positive and indole negative, and it'll grow quite well on routine laboratory media, including horse blood and chocolate agar, although for specimens from non-sterile sites, selective media such as ash downs, solid medium or broth are preferred so that it doesn't get overgrown by other flora. Burkholderia pseudomallei has a wide variety of virulence factors. Some of these include the type 3 and type 6 secretion systems, a variety of transport proteins, the capsular polysaccharide and lipopolysaccharides, as well as the flagellum. In terms of the importance of these virulence factors, the extent to which variation in bacterial virulence genes affects the clinical manifestations and outcomes of melioidosis isn't sort of known with certainty. However, an important association that's been identified is between a particular autotransporter protein associated with actin-based motility, the Burkholderia mallei-like allele of the BIM-A gene, which is thought to facilitate transportation along nerve routes and is associated with encephalomyelitis presentation.
Interesting. So that's how this little bug gets to all these places.
What does seem to be apparent is that host risk factors are particularly important. So as part of the Darwin prospective melioidosis study, which Bart will speak about further, what we found as part of that is that otherwise healthy people don't tend to get particularly sick or die from melioidosis. Those more severe presentations are associated with risk factors such as type 2 diabetes, hazardous alcohol consumption, and other types of immune suppression. So the host immune response is really important. We think particularly that neutrophil function is important.
The difference between infection with B. pseudomallei and the severity of disease being so dependent on host risk factors is in stark contrast to meningococcal sepsis, when we see people dying, and also severe staphylococcal sepsis, and indeed severe leptospirosis in some parts of the world where they have CRRs which are particularly virulent, where they have young people on ventilators who have no underlying risk factors, farmers and things like that. We rarely see healthy people getting severely ill. Our Thai colleagues have found a few potential human genotypes which may link to more severe disease, but in general, from our experience, what is mainly a Caucasian and First Nations Australians population is that the presence of risk factors is by far the strongest link to severe disease and mortality.
So the populations that are most at risk for severe melioidosis are sort of classic chronic alcoholism, diabetes. Are the elderly also in that? Do you see more severe cases in the simply people who are immunosenescent?
I have to comment on the elderly side because in our prospective study over the years, when we do our bivariate analysis, what we class as elderly moves up by 5 years every 5 years. And so, Josh, I'm not sure what you think about that issue about what is the cutoff for you're going to be more likely to get more severe disease when you are over X years old.
Yeah, it's if you're older than Bart, that's the definition of elderly.
You mentioned chronic alcohol. What we thought is that, and there's been some animal work on this, that it's not so much about chronic liver disease, but it's potentially about levels of alcohol in the blood at the time people are inoculated by inhalation or percutaneously with the Burkholderia pseudomallei, because basically the Burkholderia pseudomallei, the immune response in what may be otherwise healthy young people, if there's very high levels of alcohol in the blood, then the immune system, particularly the innate immune system, is paralyzed by the high levels of alcohol. And so hazardous alcohol use is what we talk about, in other words, binge drinking, as opposed to chronic liver disease.
So you're more at risk for melioidosis if you've just been partying. It's not necessarily a cumulative risk over time with your chronic alcoholism, or could it be both?
That's the story that we put out there as a message to the public. I think that it's a good story, but I think that there are obviously issues with chronic effects on the immune system in people who have alcohol dependence. And the other thing is, how do we define binge drinking? And again, Josh, do you remember in your days in Darwin what the description of binge drinking was?
It used to be if they drank more than I would have ever drunk in a single sitting in my life, that counts as a binge. But seriously, I think the NHMRC definition is more than 6 standard drinks in a single session.
For a male and 4 for a female, yes. That's
Yeah.
what we use that as a loose definition.
All very interesting, especially for someone who comes from a country where it is not yet endemic. And so I wanted to ask you, Bart, the known area of endemicity, as you've said, is the Asia-Pacific region, particularly Thailand, obviously Australia as well. But you two mention in the article that this endemicity has expanded now to include countries in Africa and in both the Americas, including the southern United States. So can you describe this in more detail? Is melioidosis really becoming endemic in the U.S.?
It's a very dynamic situation. It's now been over 10 years since the original genomics of and phylogenomics was done of B. pseudomallei. And what was clear early on was that the Australian isolates are ancestral to all those isolates from the rest of the world. And with the sort of molecular clock mapping, it was hypothesized that during the last ice age, somewhere between 15,000 and 100,000 years ago, B. pseudomallei moved out of Australia across land bridges. Northern Australia was joined to Papua New Guinea, and there were many land bridges across the Austronesian sort of archipelago, and moved into, during that last ice age, into Southeast Asia and then spread throughout Asia. And then there's further work being done by colleagues in collaboration with colleagues in Belgium and colleagues at the Institut Pasteur in Madagascar, which suggests that there was a movement across the Indian Ocean around 2,000 years ago to potentially colonize Madagascar and then Africa. And it sort of holds up. I mean, the timelines are a little unclear, but 2,000 years ago was when there were large migrations of people from, in fact, Indonesian Borneo across to populate Madagascar. And it's thought that there was anthropogenic sort of movement. In other words, bacteria were with plants and animals and the people themselves as they moved across the Indian Ocean to then settle in Madagascar. And then Claire Chu, a preacher from Oxford, and Mahadon, one of our Thai colleagues, looked at a very large phylogenetic set and found that the Americas isolates were even more recent, and her time clock put this as potentially moving Burkholderia pseudomallei moving out of West Africa across to the Americas. And that was very much, the model was suggesting very much at the time of the slave trade in the 1500s to the 1700s, around there, to potentially colonize South America, then Central America and the Caribbean. So that's, a few centuries ago. A lot of this will need further larger studies, but the Americas isolates are a clade on their own. And this is where the American story comes in, because a colleague from Thailand, Direk Limrathotsakhun, had done a beautiful model, again with Oxford colleagues, of where Burkholderia pseudomallei may be present based on weather patterns and land units, and thought that the southern United States, the Gulf states of the US, have certainly the potential to harbour and propagate Burkholderia pseudomallei. So it was anticipated that if it is indeed moving, which it appears to be in the Americas relatively quickly over the last century, if it is moving, it would get to the southern United States. And that story has eventually been confirmed with the publication in the New England Journal last year, 2023, from Julia Petrus, which described 3 cases in the Mississippi Delta, and they live quite close to each other and right on the Gulf state of Mississippi, which is a sort of an area where there are rivers coming in. And these were all the same sequence type. 3 individual patients from July 2020, April 2022, and then January 2023 was the most recent. And they, for the first time, were able, with sampling, and they had been sampling in the US in a number of other places, looking for B. pseudomallei in the environment, with sampling from the patient from 2022, CDC went out with the state health authorities from Mississippi, and in 2 years later, in 2022, 2 years after case 1, at case 1's house in the backyard, the front yard, and from a little pool of water, and they've shown me the photographs of that, they were able to easily culture B. pseudomallei. So all of these 3 cases were sequence type 92. There was only 3 to 15 single nucleotide polymorphisms difference between the 3 cases and the environmental isolates, suggesting that there's been a clonal introduction there. The story in the US goes back further, where our colleagues from Northern Arizona University had originally in 2008 found an Arizona case who had never left a very remote part of Arizona. And that isolate was an Americas isolate, not an imported isolate, which most of the other isolates in the US have been coming in with products like the aromatherapy spray from India and things like that, which is a tragedy in itself. But this case in 2008 was an Americas clone in this remote part of Arizona. And then there have been 2 Texas cases in 2004, 2018 who have very similar genotypes again. It's an America's strain. So both Arizona and Texas may well have endemic B. pseudomallei, although sampling done in both those places has so far not revealed any environmental isolate. It's only been in Mississippi. And then, of course, there are all the other Gulf states going across where they have hurricanes coming in and other things where they now need to be very much on the alert for potential cases of B. pseudomallei coming in people who have risk factors. And so these three people all had risk factors, the three Mississippi cases, and they were particularly unwell. And what happens is that when you have a new disease in places, even where you have very good resources for managing people, and this happens in return travelers in Europe as well, a delay in diagnosis can correlate to a poor outcome. So I think that there's a lot to be done in the US to sort of raise awareness, and potentially, I keep saying to my CDC colleagues, they've just got to go out and dig lots of holes all across the southern states of the US until they find where it is.
So Bart, speaking of all of this, how is B. pseudomallei transmitted, both more traditionally and more exceptionally?
Yeah.
And what is its incubation period? And what do we know about all of this?
The modes of transmission which are most common are percutaneous exposure, which means people usually with maybe a cut or an insect bite who then have that cut or wound contaminated with soil or surface water. So that's thought to be the commonest in both Australia and also in Asia as well. In addition to that, there is a smaller proportion, and we don't know what proportion, who, like with anthrax and tularemia and plague, can have inhalational melioidosis. And our epidemiological work, and indeed we've been able to link air sampling with an individual case who presented with mediastinal melioidosis, which was mimicking really mediastinal anthracis, so in other words, inhalation. So we think during the wet season, when there's severe weather and wind and rain, there's a shift towards inhalation, but we don't know what proportion of cases overall is inhalation. Having said that, that's also been recognized in Singapore, where when they have heavy rains and winds, and also when they have typhoons in Hong Kong, and in Taiwan, they've done some excellent work on air sampling with typhoons and found that there is aerosolization of B. pseudomallei, and this is why people are concerned about it being a potential biothreat agent. So that inhalational disease, if it's a large inoculum inhaled, then people are much more likely to become unwell. And that, in theory, would be how a healthy person could potentially become critically ill if they had a large inhalational inoculum, and they could potentially progress to severe disease. But the percutaneous disease overall is thought to be the commonest presentation, particularly when it's not that wet and windy. And then the third way of being infected is ingestion. And that's where it's pretty interesting, because it's been very much linked with kids ingesting untreated or unchlorinated water supplies in Southeast Asia and South Asia. And there they have the commonest presentation in kids in Cambodia and in Thailand, and in Laos is actually parotid abscesses, which our colleagues there have documented, which is incredibly rare in the Australian cohort. And that's thought to represent potentially ingestion, and they have more liver abscesses as well. So ingestion of unchlorinated water is a possibility. And then the final thing, the unusual things, is like the aromatherapy outbreak, where that was a spray to spray the room, which was a aromatherapy spray with rare gemstones, but selling for a very cheap price at a big retailer in the US. That was a product made in India, and unfortunately there were 4 cases in 4 separate states in the United States in 2021, and 2 of those cases died, including a child. And that was a big issue for the US, and the company had to recall all of those aromatherapy sprays throughout their shops throughout the US. And there have been many other sort of unusual ways that it can get into other countries. Potentially it could contaminate medicinal products as well, as we know with Burkholderia capacia and a number of other environmental organisms.
So have there been cases of human-to-human transmission, animal-to-human transmission?
We like to sort of say it's not a zoonosis. The term that David Dance likes to use is a sapronosis. So both humans and animals get it from the environment, but it's not transmitted between humans and animals. Having said that, we're aware of 3 cases in Australia which we think is zoonotic. One was a veterinarian who was doing an autopsy on a camel that died with multiple abscesses in many organs internally, and the vet cut their hand. Another's an abattoir worker who was slicing a liver of a pig who got a skin lesion, which was B. pseudomallei. We thought that was inoculation from that infected pig. And then we also had a farmer who had goats who got a milker's node literally on their finger, and that was a goat with mastitis. And so we think that was potentially maybe mosquito bite or a cut that was again through the contaminated milk, then infected, and that was the root of infection. So they're the 3 rare zoonotic cases that I'm aware of, and none of those has been recent.
With the clade that came to the Americas probably via the slave ships. So it came in the water that was being transported, or it was environment to environment in the end, right? It wasn't humans bringing it to humans in the Americas.
Zella is actually looking at our phylogenies in Australia, and we've recently had, or over the last 10 or 15 years, had now 2 strains which are not Australian strains that have come in from outside, and we're trying to figure out how that's happened. So even here in our highly endemic area of Northern Australia, we have had strains come in from Asia in recent years that are worrying us. So Ella, do you have comments on how it might be going around the world?
Yeah, we don't know with certainty. So what I would say is that isolation of Burkholderia pseudomallei from a clinical specimen is a diagnostic of melioidosis. Humans don't get colonized with Burkholderia pseudomallei, and there are large studies in Thailand looking at throat swabs and so forth that have shown that. And we think that that's why it's so phylogeographically restricted, why the populations in Australia, Asia, Africa, and the Americas remain so distinct, with just a couple of exceptions. So as Bart mentioned, we have had 1 and more recently 2 Asian sequenced types arrive here in Australia and cause melioidosis cases here and become established, and we don't know how they got here. So it could have been through imported plants or animals or migratory birds, or Bart has the Free Willy hypothesis, which he might want to elaborate on.
What's that, Bart? What's the Free Willy?
Well, I mean, this could have been my favourite movie, was Free Willy, because in Ocean Park in Hong Kong in the 1980s, there were marine mammals who were dying from melioidosis. And so they were able to actually show that potentially they were acquiring it with typhoons, maybe through their blowholes. So you can imagine when you've got a big dolphin or even an orca or something, how on earth do you dose ceftazidime in those animals? And how do you actually give them the ceftazidime? But the veterinarians at Ocean Park in the 1980s and through to the last decade of last century basically had to work on trying to minimize their deaths in these marine mammals. And they found that by changing the environment, so when there were typhoons and severe weather events, there was not bounce back of wind and rain off the surrounding sort of hilly, grassy areas going back into to aerosolize and then into Ocean Park. My point being is that these marine mammals can travel, obviously migrate thousands and thousands of kilometers. And so I was just hoping one day we'd be able to publish the Free Willy hypothesis, that's how maybe it moves around the world in at least one case. And a very kind editor, when we put it in some paper, was very kind and said, well, let the Free Willy hypothesis go just because it's sort of a good story. But we are honest. It's entirely speculative.
It's a good theory, though. So I want to bring us from the bench back to the bedside now. Ella, can you just tell us, look, most of our listeners have probably never seen a case of melioidosis. So what's the classical clinical presentation of this disease, and what's the kind of common range of presentations that you see?
Yeah, so melioidosis can have very wide variety of clinical manifestations. Almost any organ system can be involved. However, pneumonia is the commonest presentation, accounting for around half of cases. Most cases are acute, presenting with acute onset of symptoms soon after the inoculating event. From a pneumonia perspective, it can be like a focal lobar pneumonia with dense consolidation, or in some cases can be have multifocal involvement, sort of more suggestive of bacteremic spread to the lungs. Chronic melioidosis tends to present in sort of one of 2 ways. It can be a chronic pulmonary presentation mimicking tuberculosis, so with cavitation and a presentation of weight loss and sweats. The other chronic presentation that we often see is cutaneous disease, so presentation with a non-healing ulcer that's not responding to the usual antibiotics given for skin and soft tissue infection. Other than pneumonia and cutaneous disease, abscesses of the internal organs, including the liver and spleen and kidneys. In Australia, prostatic abscess is a common presentation in men, presenting with fever and urinary retention. And then there are a number of other more rare presentations, including encephalomyelitis and meningitis, and brain abscess, mycotic aneurysms. But we have seen a number of patients present with para-intestinal inflammatory sort of phlegmons or masses. So really it can present in many, many different ways.
It can do anything, right?
Yeah.
It can do lots of different things,
Yeah.
but so you just have to have a high index of suspicion in the right time of year and the right place. You touched on something that Angela asked before that I don't think we finished talking about, which is the incubation period. So what is the incubation period?
So we've looked at this as part of the Darwin prospective melioidosis study. So many of our patients, when taking a history, recall a likely inoculating event, and they're often things like having cuts or scratches while gardening or being caught out in particularly heavy rain. And by documenting the time of those exposures and looking at when people develop symptoms and present, the median incubation period is 3 days, but it can be between 1 and 21 days.
Okay. Maybe can I just tangentially go to a question I was going to ask to Bart about this incubation period question? So there was concern after the Vietnam War that people might have latent melioidosis that reactivates later on, as happens with TB, and they labelled this the Vietnamese time bomb. So can you tell us a bit about that? And was that a real thing, or was that a storm in a teacup?
Yeah, thanks, Josh. First of all, stepping back, overall, of our patients from our Darwin study, 88% are acute illness with a recent infection with the incubation period as short as 1 day and within 3 weeks almost always. So that's 88%. And then 9% have the chronic illness with the two features, pulmonary and cutaneous, that Ella described being the commonest. And we define those as being sick for more than 2 months. So that leaves fascinating situation of activation from latency, which of course the model for that is tuberculosis, where in many studies the majority of cases of tuberculosis are thought to be activation from latency. So what our work has shown is when we analyze it, that activation from latency is actually incredibly rare in melioidosis, but it was thought to potentially be an issue with the large number of return service people from the Vietnam War. And there was an estimate based on serology, and serology is always slightly dodgy with not just melioidosis but other things. There was an estimate that there were 225,000 return service people to the US who had been infected in their time in the paddy fields and other things. So that's based on serology. And really over the years since then, there's been really probably less than 100 cases who have been true activation from latency. But what a colleague of ours, Matt Howes, who is a registrar here, is now an ID physician, has described and published recently in the American Journal of Tropical Medicine and Hygiene is re-looking at our activation from latency and looking at the historical cases to confirm that the majority of cases in the American literature were in fact more remitting, relapsing chronic melioidosis, which was partially treated with antibiotics and then would go away. So not true, completely asymptomatic and then activating many years later. So in summary, it is very different from tuberculosis and activation from latency. While we have clear cases and the longest period that is 29 years in an American person. So 29 years after being in Southeast Asia, that person activated, and that's very rare. So our emphasis is very much on what's happening in the current wet season and trying to prevent people from getting infected in the first place, and then rapid diagnosis.
You did not yet mention the seroprevalence studies, which you do mention in the article. Can you tell us a little bit about seroprevalence in endemic areas?
Thanks, Angela. So what I talked before about was just what had happened in return service people from Southeast Asia, and I think that estimate of 225,000 is a way overestimate of people infected, I would think, and their cutoff was probably way too low, but that's just speculation. We'll never know. But what we know from studies in Thailand, and colleague Alan Cheng and the colleagues in Thailand working with Alan, and studies here in the Northern Territory and our colleagues in Far North Queensland, the background seropositivity rate varies a lot between places, but irrespective, the vast majority of people never get clinical disease. So, for instance, in Thailand, you have seropositivity in over half of the kids by the time they're maybe 10 years old with the serology assays they're using. And potentially maybe those kids are getting infected on and off, but they're healthy kids and never getting clinically unwell. Some will unfortunately get parotid abscesses. There's some suggestion, I think, that these kids may be starting to get some level of immunity, which is a good thing from the point of view of potential future vaccines. In Australia, our seropositivity rates in the general population in Northern Australia is substantially lower, around 5%, and we think that's because we have treated water supplies. So despite that, it still means that for every case we have a definite culture-confirmed melioidosis, which means they're clinically unwell. For every case, there's probably going to be at least 100 people who have been infected who will never get melioidosis. So seropositivity is interesting, and we need to do prospective studies and see what it is that unmasks disease under certain circumstances.
Ella, how is the diagnosis made typically? And will there be more rapid, more sensitive tests anytime soon?
Yeah, so culture of Burkholderia pseudomallei from clinical specimens remains the gold standard for making a diagnosis of melioidosis, and that's not difficult to do. So we would recommend that for anyone in whom melioidosis is suspected, that they have blood cultures, urine, sputum if they can produce a specimen, and any other specimens from suspected sites of infection, so body fluids and pus aspirates and so forth, sent for culture. As I mentioned earlier, it will grow on routine media but can be overgrown by other colonising flora from non-sterile sites. It can take 24 to 48 hours to grow, and then the identification in the laboratory can be challenging for laboratories that aren't familiar with the organism. So up until recently, it hasn't been included in vitro diagnostic databases used with the two main MALDI-TOF MS systems used in diagnostic laboratories. That's changed relatively recently, which I think will be an improvement. And so, for example, our laboratory at Royal Darwin Hospital up until recently was relying on automated biochemical testing with the Vitek 2 GNID card, but that doesn't perform perfectly and can misidentify the organism as particularly as Burkholderia cepacia complex. And there have been reports of misidentifications resulting in patient harms and laboratory exposures related to difficulty identifying the organism. In terms of rapid diagnostic tests, I think there are some exciting developments on the way. So there's a lateral flow immunoassay for detection of the organism's capsular polysaccharide, which is highly specific. To date, the studies, when it's used directly on clinical specimens, have shown that it doesn't perform as well as culture. However, I think it's something that's suitable for low resource settings where culture facilities may not be available, and when used there, it would very likely result in greater diagnosis of melioidosis cases, which is a good thing.
So wait, Ella, these lateral flow assays, you put pus or sputum or something straight on the card and you get a
so
line?
there are some fairly straightforward, simple sort of specimen preparation steps, including mixing it with a buffer, and then it goes onto the card for direct detection of the capsular polysaccharide within the clinical specimen. It can also be used for organism identification on bacterial colonies and in the broth from flagged blood culture bottles as well.
What about molecular techniques, PCR and so on?
There's a specific PCR assay targeting the type 3 secretion system that's been in use at our laboratory and others for many years now, and we have as an adjunct to organism identification. However, it's not available commercially to my knowledge, so in our laboratory it's an in-house assay and not something that's widely available in non-endemic settings, for example. That's been looked at when used directly on clinical specimens as well, and similar to the lateral flow immunoassay, the sensitivity when used directly on clinical specimens is less than for culture. Neither PCR nor antigen detection are sensitive enough to replace culture as yet.
What is the yield of blood cultures in somebody who's not febrile for this bacterium? And second question, should you even be suspecting melioidosis if somebody is not febrile? Would you do blood cultures in an elderly person, for example, who may not make fever?
Approximately half of the cases in the Darwin prospective melioidosis study have positive blood cultures. So we would recommend doing blood cultures in all cases where melioidosis is suspected. I would say, though, that among those that are not systemically unwell, the proportion that are bacteremic is lower, but it is still worth doing that test to see whether there's bloodstream infection.
Parallel to that, with the people who have these, who are healthy, who have an inoculating injury and just develop a skin sore which does not respond to standard skin pathogen therapy, they invariably will be blood culture negative. And these are healthy people, and they are basically containing their infection through their innate immune system and the adaptive immune system at the level of the skin. And the paradox is that in the people with more severe disease, we just don't see a primary inoculating site in those people. So those people, particularly kids who have these skin sores, occasionally they will have lymph node involvement as well as part of their ability to control infection, but bacteremia is incredibly uncommon in those people. But they're a minority of the patients overall.
Ella, going back to the respiratory specimens, you had mentioned earlier that there's not really a carrier state for this bacterium in humans. So when it's positive, it's truly positive. You don't have to worry about, is this a colonizer? Is this a bystander correct?
Correct.
It's always
Except
nice
that latency is there in some people. So there will be organisms hiding out, as with tuberculosis, in some either professional or not professional sort of cell which has ingested the organisms and rounded up and sitting in their lungs. Where do you think, Ella, it's hanging out? Spleen and lung would be the main things?
We don't know.
Yeah, that's funny because I was about to say, it's so nice when we can take away a little nuance, when we can say that if the organism is there, it's real, it's pathogenic. And then Bart just injected nuance.
The summary is basically if you find it, it's an infection, right? It needs to be treated.
So
exactly.
they're non-culturable. That's the thing. In those so-called latent cases, we don't culture it. But there was a very nice case report of a person in, I think it was Malaysia, who had a motorbike accident, a healthy guy, and he ruptured his spleen. And in theatre, when they took his spleen out, and then the pathologist looked at it had a little granuloma in it, and he then subsequently became blood culture positive as he was recovering. So in that person, he was completely asymptomatic, and there was a little granuloma in his spleen.
But let's move back sort of from the specifics back to the general, and also from the bench back to the bedside again, for all our clinicians in the audience. I've got this patient in front of me, pneumonia. I think they've got melioidosis because they just came back from a holiday in Darwin, and it's the wet season, and they're a diabetic and hazardous alcohol drinker. How should I treat them?
It's nuanced, isn't it? Because we are very much guided by how sick the person is. So if we think the person is sick enough with sepsis that they're heading towards intensive care management, and that they are potentially going into a situation where they may have a life-threatening illness within the next 24, 48 hours, then we would empirically go to meropenem in those individuals. If there's someone who is a community-acquired pneumonia and eventually they may become blood culture positive. They may be blood culture positive, which you find out 48 hours later or 24 hours later, but they're not too bad and you're going to treat them on the general ward. We avoid going straight to either meropenem or ceftazidime in those people and use our standard protocol for treating community-acquired pneumonia, which for us, if they have risk factors, we actually use ceftriaxone, recognizing it's not a great drug for melioidosis. We use ceftriaxone plus doxycycline on the wards, and if they have no risk factors and they're on the wards, then we would follow the Newcastle protocol and use intravenous penicillin, which I think, Josh, you're still very happy with.
Yeah, yes, plus gentamicin if they have severe pneumonia. But so that's empiric therapy, Bart. And so let's say now we have the cultures back, we know this person has melioidosis. What's the directed therapy and the duration?
Thanks, Josh. So I'd be interested to ask you, because you were very much part of our evolving guidelines on all of this with all of our registrars over the years. So we basically talk about the intravenous phase and then the eradication phase. And the intravenous phase, if they're outside of ICU, then we would use ceftazidime, and we can then also put them on elastomeric infusers through our hospital in the home. Meropenem's not stable for our hospital in the home out of hospital therapy through the peripherally inserted central cannulas. So we would use ceftazidime if they're out of the wards. If they're in ICU, we'd use meropenem while they're sick enough to be of concern and in ICU. And the intensive phase is directed very much by their foci of infection, and the minimum we would have is 2 weeks. Although it is true that in some of the children with just skin disease only, our colleagues are happy to go to oral therapy after a day or two of initial IV while we're excluding other foci. But otherwise, it's a minimum of 2 weeks, and we go out much longer in people with bone and joint infection or neurological infection. So that our median time now of intravenous therapy of our intensive phase here in our Darwin cohort is 4 weeks. So we have quite a lot of people who have more than one lobe of lung involved, for instance, who are bacteremic as well. So we have basically an algorithm which our fellows can use to determine whether we think it's okay to just go with 2 weeks IV, or we should go out to 3, or we go out to 4, or even longer with neurologic disease, abscesses which may require repeat drainage, such as prostates and bone disease in particular. So that's the intensive phase. And then we step down to the eradication phase, which is 3 months, calendar months is what we do for simplicity, in everyone except for those with CNS disease and bone disease, osteomyelitis, and also, as Ella mentioned, the rare but important mycotic aneurysm or pseudoaneurysm. We go out to 6 months of cotrimoxazole as our first line of therapy, which our Thai colleagues prefer also as their first line of therapy, with doxycycline as our alternative if people are intolerant of cotrimoxazole or develop acute kidney injury or other adverse effects from the cotrimoxazole.
You mentioned the algorithm about how long to treat IV. That's been published, right? So people can access that if they want to.
So we've had a series of papers. So Matthew Pittman published it first, and about the goal-directed therapy, and he published it as the new paradigm which is based on the severity of putting together what is the worst organs affected and everything. So Matthew Pittman published that in PLOS NTD, and then Richie Sullivan, who's worked with you, I think, as well, Josh, now back in New South Wales, and published a revision of that in 2020 in PLOS NTD. And then we've just put out the 2024 revised guidelines, which just have a few nuanced changes to the duration and some more detail about what we do under certain circumstances where things aren't working as you would expect. And that's published online in the NT Disease, Northern Territory Disease Control Bulletin in January 2024, and it is available through the NT Department of Health.
Okay. And then Bactrim, cotrimoxazole, what dose?
So the dose we used to, in all adults, pretty much just try and aim for the 2 double strength BD tablets, which was basically 8 milligrams of trimethoprim, 40 milligrams of sulfamethoxazole, up to the 2 double strength tablets of cotrimoxazole twice a day. But we have now got based on the work of our Thai colleagues, we're aligned with them where if you're between 40 and 60 kilograms, so a fairly smallish adult, you can go to a lower dose, and that might be, for instance, 1.5 double strength, which is 3 single strength tablets. I don't know, Angela, whether your cotrimoxazole comes in Bactrim DS and Bactrim SS and all that sort of stuff.
Yeah,
and so,
yeah, it does.
So that dose, which we also in kids recommend, is rather than 8/40, our original dose has been cut back to what is 6/30 milligram per kilogram twice a day. But we have weight ranges because it makes it a lot easier. You can either have basically, a double strength BD or 1.5 double strength BD, or the maximum dose of 2 double strength BD with folic acid to try and protect the bone marrow a little bit. So that's our eradication phase. And the doxycycline is 100 milligrams twice a day. For the duration. And the other thing is there is a regimen that we occasionally have to use when we can't use doxy or cotrimoxazole, which is amoxicillin clavulanic acid. And the important thing there, which Alan Cheng worked on with Australian and Thai colleagues, was that it has to be a 4-to-1 ratio of amoxicillin to clavulanic acid. So not the augmentin duo fort, which is basically 125, 875, but the augmentin duo, which is 500/125, a 4-to-1 ratio. And the problem with that is you need 20/5 milligram per kilogram 3 times a day, which is for many adults 2 or 3 of these augmentin duo tablets 3 times a day, which will make many of those people so nauseated that they stop. So it's our third line because it's impractical in the doses that is required according to the PK studies that Alan did.
Wow, that's really, really helpful. Here's my $10 million question for both of you. You're doing this prospective cohort study, which is really helping the entire world understand this disease better. If you had $10 million right now, what studies would you do? What are the most pressing questions in melioidosis right now?
Ella and I did discuss this, so I'll leave Ella to provide our consensus answer.
So if we could spend the 10 million on anything, we would like to take the opportunity to mention that we're hosting the World Melioidosis Congress here in Darwin in October of this year, and we would love to use some of those funds to bring as many people to the conference, including from low and middle income countries where melioidosis is such an issue, to the conference to share their knowledge and for everybody to learn from each other. The other priority we feel is around diagnostics, particularly in low and middle income countries, so improving laboratory capacity to make the diagnosis such that people can get the appropriate treatment and ultimately save lives from melioidosis. Bart.
Thanks. Yeah, thanks, Alice. If I could just point out that, and Josh is aware of our close connection here, both physically and in relation to partnerships with Timor-Leste, one of the newest nations of the world. And we had known for 20 years that melioidosis was likely to be endemic in Timor-Leste based on serology studies in refugees from 1999 when there was the troubles and following independence. It took 20 years for support to come in to have a blood culture facility in Dili, the capital, which about 3 years ago was instituted through support from the Fleming Fund and the Australian government's Department of Foreign Affairs and Trade, the Fleming Fund from UK. And with that microbiology laboratory, they were readily able to get 3 cultures of Burkholderia pseudomallei and confirm for the first time that melioidosis is present in Timor-Leste. So it's not known how much it is in other parts of the country, but that's an example which will be repeated many other parts of the world, which the maps done by the global modelling by our colleague Derek Limmer-Thotzakun and others suggest that there's still at least another 20 countries that are likely to have endemic melioidosis, but from where the laboratory resources are so difficult that they don't have blood cultures. And I would give a shout out to our European colleagues, our Swiss colleagues, and also colleagues from Austria, colleagues from the Netherlands, colleagues also from Belgium, who have done really good work, particularly in Africa, where a lot of it is around basically, as well as rapid diagnostics, it's around blood culture capacity so that you can grow the organisms that are causing so much sepsis. And there's a lot of movement in this space. And I think that in the future, whether we'll be able to cover the whole of the world with appropriate resources, but that's an aspiration that we can all have, particularly in the area of tropical medicine.
So that's a nice segue to kind of closing question. So maybe for you first, Bart, what's your key messages on melioidosis you want to get across?
I'm going to pass that to Ella because I think that, I just ramble on.
But Bart is a very good delegator. That's what you learn when you work with him.
And then,
So,
Josh, I'd be
Ella.
interested in your thoughts from your time up here as well. So maybe can we go to you first, Josh? What are the priorities? Is that all right, Angela?
That's absolutely right. Josh should lead.
Yeah, sure. I mean, I haven't seen a case of melioidosis since I left the territory about 10, 15 years ago. I saw a lot of it up there, especially in the wet season as a registrar. It makes you very busy. Yeah, but I think there are still ongoing questions. We've discussed most of them today. Diagnostics, therapy, how long do we really need of intravenous? How long do we really need of oral? Yeah, so for me as a clinician, it would be mostly around the therapeutic area. So Ella, tell us what are your key messages you want to get across?
So key messages would be to think about melioidosis, particularly in people who are returning from endemic areas, in those with risk factors of diabetes, hazardous alcohol consumption, chronic kidney disease and other immunosuppression. To make the diagnosis culture. Tell the laboratory that's one of your differential diagnoses so that they set the specimens up on the correct media. When you make the diagnosis, look hard for foci of infection, do imaging to make sure the patient doesn't have an internal abscess, and give adequate treatment to ensure the person doesn't relapse. Because if you don't give an adequate duration of treatment or drain the pus, have adequate source control, the chance of relapse is high.
Nice summary.
Thank you so much to Bart Currie and Ella Meumann of Royal Darwin Hospital in Darwin, Australia. Their concise clinical review can be found at the CMI Communications website, which we'll publish in the show notes. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Josh Davis and Angela Huttner, editors at CMI Comms, ESCMID's open access journal. It was edited by Katie Hostetler and peer-reviewed by Dr. Julia Ohan of Yerevan State Medical University, Armenia. The theme music was composed and conducted by Joseph McDade. You can subscribe to Communicable on Spotify, Apple, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in infectious diseases and clinical microbiology further along.